As many of you know, I was appointed to the Universal Healthcare Joint Task Force a little over a year ago, and have served out a term before that. I was very active testifying before different subcommittees. Thank you for inviting me to speak. Final report from the Joint Task Force on Universal Healthcare was delivered to the legislature on September 30th. Based purely on hours of work and number of meetings, this task force has been among the most extensive explorations into universal care by any state, probably at the national level as well. Some will say that the report is the best thing ever. Some will lament that lack of solutions provided in some areas. I'll speak mostly about the process of the task force, but add a few of my own high-level observations. Next month, I believe the program will have Karen, Alex, and Linda will go into the details of the task force report. I will speak just a little about the team, the assignment given to the task force, the problem statement, the analysis work, the recommendation from the task force to the legislature, a little bit about the report itself, and some personal takeaways, as I mentioned before. I will begin by identifying the task force team. Senate Bill 770 required 4 legislators be assigned to the task force as non-voting members, 1 from each party in each of the 2 legislative chambers. That requirement has never been achieved. Initially, Republicans assigned no one from the Senate. Then, as legislative committee assignments were changed with the start of the 2022 legislature, the Republicans assigned Senator Dick Anderson from the coast to fill the empty Senate spot. But at the same time, the Democrats reassigned Representative Marty Wilde away from the task force without replacement, leaving the task force with 2 Republicans, but only one of the 2 Democrat seats filled. The legislators did not participate much in discussion, but acted as interested observers. Senator Dick Anderson was a nice addition in that he attended almost every meeting and many of the public input sessions as well. Senator James Manning Jr., of course, as chief sponsor of Senate Bill 770, always popped into the meetings from time to time. From a staff standpoint, the early process was led by Sarah Nipper and Laurel Swerdlow from the Oregon Health Authority. Then in the second year, Daniel Dietz was hired by LPRO, that's Legislative Policy and Research Office. LPRO took over the main staff responsibility for the task force. Devlin Prince was hired by OHA, Oregon Health Authority, to help with the task force in place of Sarah and Laurel, who were given other important assignments. Here is a list of the participating task force members. Chad Chadwick, Glenn Claybrooks, Michael Collins, Dwight Dill, Warren George, Bruce Goldberg, Xenia Junker, TK Keene, Sharon Myron, who's a Multnomah County Commissioner, Sam Metz, Cheryl Ramirez, Les Rogers, John Santa, Chuck Sheketoff, and Christy Simolo. Senate Bill 770 required a very specific range of members by heritage, representation, personal experience as patients and providers. I was appointed in late 2021 to meet the SB 770 requirement that 1 member must have expertise in fiscal management and change management. Here is our family portrait. taken at our final meeting on September 29th. The family analogy is appropriate because though we sometimes fought like brothers and sisters will, I can say without reservation that I love these people as family. Maybe that's what the Stockholm Syndrome does. Bruce Goldberg was elected as the task force chair. Ed Junkins of Corvallis was initially named vice chair, but replaced by Xenia Junkier when Ed moved to Indiana to take a job at Notre Dame. I'll give you just another second to look at these people. All very pleasing to see for me to see them, considering that until this final meeting, few of us had met other than on screen. And we had not seen each other in person. The task force was supported in contacts with CBIZ Optimus for building a financial model of the single payer plan. Shane Mulford of Optimus was a vital part of the task force process. It was good to see Chris Alanak of the Legislative Revenue Office. In 2018, a group of 8 people from Mid-Valley, many of you here, worked on universal care funding design. Betty Johnson talked Dan Rayfield into sponsoring our group. We were given full access to the resources of the Legislative Revenue Office under Chris Alanak. Mid-Valley can be proud that many of the revenue concepts put forth by the LRO to the task force came directly from the cooperative research we instigated in 2018. Betty would be pleased.
Okay.
The task force was also especially helped by attorneys Aaron Fuse Brown, Elizabeth McCuskey, on how to deal with the ERISA law. About a dozen other speakers, including OSU's Chun-Wei Chi, were invited to speak. I was invited to speak about the Elway poll, which was commissioned in 2019. The task assignment came from SB 770 itself. Task force was created by the passage of Senate Bill 770, which charged us to design a healthcare plan system that was equitable, affordable, comprehensive, provides high quality healthcare, is publicly funded and available to every individual residing in Oregon. The Senate Bill 770 addressed many issues that we would agree on as values and principles. And it created a very good framework to start the task force discussion, but in a few cases, as our understanding grew, the task force had to find its way in uncharted waters, having to prioritize principles which were eventually found to be in conflict with each other. Here is an example of potential conflict. Senate Bill 770 explicitly instructed the task force to include out-of-state workers employed in Oregon, and yet including them solely by coupling their eligibility to their employment status seemed to violate our own rules and give us some decisions to make. Although an effort was made to address most of the issues raised by SB 770, the task force voted against an option in SB 770 to start a separate task force working on long-term care. It was judged that that it was just too much for the task force and the existing staff to bite off. The sticker shock was likely to be a wet blanket to the remaining process. So it's still out there yet to be done. In some ways, Senate Bill 770 concentrated more on mechanics without clearly stating the problem, but it didn't quite identify the specific problem. And we were concerned that without a more specific problem statement, we might accidentally solve the problem, solve the wrong problem, who knows? With Glendora Playbrooks, we assigned ourselves the task of boiling the problem down into one sentence and came up with, our healthcare system is financially unsustainable, harmfully complex, and socially unjust. This problem statement focuses on 3 problems which can be broken down further. Current system is financially unsustainable, cost rising faster than income, meaning that diminishing fraction of the population can afford their own health care, and at the same time, draining public and private services for subsidized care financed by fewer and fewer people. Harmfully complex, most of us know too much about this. It's hard to evaluate our alternatives, the complexity, discourage patients from going to the doctor, and this actually discourages doctors from wanting to be providers. Unreadable bills, complex coding that sometimes requires paid navigators. And the system is socially unjust in many ways. Lower reimbursement discourages care for Medicaid and Medicare patients. Financial stress on sick and injured results in disparity of care and early death. Coupling with employment reduces jobs, especially for lower middle class populations. Providers centralizing high income instead of being distributed according to population. Care is no longer available on neighborhood basis in many areas. Separate risk pools lead to elaborate and widespread gaming of the system to gain group advantage at the expense of others. Unequal outcomes for historically disadvantaged populations are widely known, and we have too small a pool of provider diversity. The task force divided itself into 11 subcommittees to meet with experts and make recommendations back to the full task force. These 11 groups are eligibility, benefits, and affordability tag, or the tags are technical advisory groups, provider reimbursement tag, finance and revenue tag, governance tag, consumer advisory committee, intermediate strategies work group, expenditures and revenue analysis work group, which began in 2022 and took over the incomplete work of the finance and revenue tag. Also had public engagement ad hoc work group, communications ad hoc work group, special interest feedback work group, steering committee, and ad hoc planning group. I participated personally in 6 of the 11 subcommittees. In addition to the 11 subgroups, the task force sought feedback and ideas from 21 meetings with public and medical entity stakeholders. In regarding the 6 regional community listening sessions, I was proud that while some regional listening sessions had no more than a half dozen people show up, the Mid-Willamette Valley session held on June 25th had about 80 people, even more than the Portland session. Lara media staff, as well as state staff, remarked that the people who came to the Mid-Valley session were not only more numerous, but were noticeably more knowledgeable about the details of universal care and provided a higher level of questions and comments. I credit Mid-Valley Healthcare Advocates and their educational forums and programs directly for this difference. After analysis and listening to public input, the task force made one main recommendation to the 2023 legislature. Given the problems with the existing healthcare system identified in public input, given the significant potential of a single payer system, the Joint Task Force on Universal Healthcare recommends that the 2023 legislature appoint a governor's board consistent with SB 77 to complete a single payer implementation plan for review and consideration by the 2025 legislature. The final report contains 123 pages, including 6 appendices. The general mood of the members at the final vote was some frustration that more of the details hadn't been worked out, particularly in the areas of funding. Not everybody agrees with every word in the report, but the report does represent effort of the group members. Glendora Claybrooks cast the one dissenting vote, which was a symbolic vote against the process by which a funding plan was proposed, but never given adequate vetting or consideration against alternatives. Although the report itself will be covered in more detail next month, I have chosen 4 takeaways to talk about briefly from my own personal experience. Takeaway number 1, the advantages of a single payer system are real and address the problem. Going back to the problem statement that our current healthcare system is financially unsustainable, harmfully complex, and socially unjust. Single payer system can address each part of this problem statement. Savings are potentially quite substantial. We identified 12 to 16% in gross savings. The complexity could be virtually eliminated. A system with no bills certainly has no complexity for the patient. And injustice could be addressed in many ways that no other system could achieve. For instance, if the state is contracting with providers to provide care, the state can have, or the single payer can have some ability to say, we don't need more providers in Lake Oswego. We need some in Hermiston and North Portland, for example. There is some ability to say when and where care needs to be delivered to serve the population instead of serving the income streams. Takeaway number 2, there are major federal obstacles to a state-based single payer system in the form of Medicare and ERISA. The benefits of a single payer system in addressing cost complexity and social justice require 100% consolidation into one system. Federal approval is needed to combine Medicare and other federal programs into a single payer system. Well, some point to a year-by-year waivers might work. That makes me very nervous. This cannot be just a year-by-year experimental waiver. For the state to take on this responsibility, it must have a long-term federal policy to provide stable funding at current levels or higher indefinitely from the federal program sources. The ERISA issue is also a potential federal obstacle. Under current ERISA law, self-insured employers are not subject to state insurance law, and they can't be forced to participate in a single payer plan, except voluntarily. Again, unless there is 100% consolidation under the single payer plan, the benefits are not possible and the costs will go up instead of down. Takeaway number 3, what could possibly go wrong with a committee of 20 participants? Well, plenty. To begin with, there were several different competing visions and they didn't all line up. In an effort to keep the peace, some major considerations were never, or some major differences were never resolved. We spent months, for instance, on minutia of how to define residency, but never once clarified the definition of a single payer. It didn't help that Senator Manning was telling people at various sessions that each person in the state can have their own personalized single payer system. That does not help to public understanding what is a single payer system. Or many people still believe, why don't we just have a public option? And there's many reasons why, of course, that won't work. And, you know, more things that are unresolved. Is a state single payer system a state-run insurance company, or it is publicly contracted care, which makes all insurance unnecessary. With my business background, the idea of avoiding tough questions was an unthinkable strategy, left me very discouraged during those moments when I was not merely despondent. In the final report, it is noted that all previous attempts at state universal care based on public funding have failed due in major part due to the avoidance of a taxation plan or due to fears that public funding would not be politically popular. Oregon, unfortunately, is still not an exception to that rule. After many dozens of meetings on the subject of funding, only one taxation plan was considered. After further study by the task force and consideration of public testimony against the plan, the task force voted not to recommend that plan, but to leave taxation to the legislature. There are, of course, things to be said. Taxation plans truly are hard to agree on. And one of the things I notice is kind of the political effect. Although the Elway poll of Oregon voters showed 62% willing to pay a new tax 2 to 3 times the size of Oregon's income tax in order to achieve universal care, the political operatives, including those influencing the task force, feel a strong responsibility to protect their own constituents from the cost. The idea of everyone paying seems to be foreign to the political process. This leads to proposals of how to shift the cost to satisfy compartmental interests rather than concentrating on the universal benefits. Where do we go from here? The recommendation to appoint a governing board will go to the legislature, and Karen, you might be able to report when I'm finished on where that is in the process. I think it will be assigned a bill number to appoint a governing board to develop an implementable plan, and we'll see what happens with that. One of the questions that people are asking me is, given the difficulty in achieving good answers in a political environment, can citizen groups get farther in planning for the financial plan, given that citizens seem more willing to plan to fund the program than their elected representatives, which could lead to a ballot measure rather than legislative action. One thing is for sure is effort needs to be concentrated on passing congressional law to better enable state-based universal care programs. One of the things that I look for, based on the results from the Elway poll and based on numerous other things, including who showed up for the provider and hospital meetings, mostly rural hospitals. So I look to rural support for universal care, both from providers and citizens. And I think one factor in the rural areas is that people really are faced with the potential of losing their local medical care, or having it bought out by out-of-state interests. And I will conclude with just one comment. As I mentioned, I'm very proud of Mid-Valley Healthcare Advocates. you know, I think they have a better understanding than some other groups in the state, and just urge you to stay involved and stay educated. And will make a difference. So that's, I'll stop the screen share, and I will be open to a few questions, or if people just want to comment, that's fine too.
I'm going to be carrying the mic around to people as they raise their questions. I hope I don't get much of that. As I get in front of the speaker, I may get some more of it.
First off, I don't really have a question, but Warren, thank you for your work. It's really extraordinary. And when we talk about Mid-Valley leading the way in having an educated and aware group of people in the Valley, you're a very big part of that. And thank you for this tonight, because there's a whole lot of this that most of us haven't really known. So thank you. Questions or comments?
Louise Farrell.
So how about federal employees and veterans? How does this affect them? Would they be covered under this plan, or stay the way they are?
Okay, I see that as a two-part question. The people who are served by the VA, I mean, there are a class of organizations which have their separate budgets and serve a separate clientele, not open to serving the public. So in our vision, the Veteran Administration, Indian Health Services, school nurse programs, on-site programs operated by employers who have either very remote sites, all of those things, as well as infirmaries at state universities and at state prisons would continue operating the way they do now, and on the budgets. But presumably people under those programs would have increased opportunity maybe to see more convenient help. As far as like government employees, they should be melded in just as any other resident of Oregon, with some funding by the federal government. And thank you for the question, by the way.
Sorry for the woo. Oh, for the question. Okay.
So, Warren, I have a question. Warren, can you hear me?
Yes, I can hear.
Yeah. You know, you mentioned that the task force didn't really solve, quote unquote, the issue of funding. But when I read the task force report, it kind of outlined the framing of how one would do it, you know, taxation and employers pitching in and so on. Are you thinking more that specific numbers of like what the tax rate or this and that, or are you thinking that we haven't addressed the funding issue at all? Because it seems to me that you have touched on this funding issue.
Okay, thanks for that question. And yes, it's relatively certain that funding would consist of some employer contribution and some individual contribution. And from that standpoint, the the one that was presented at the public input sessions does show how that could work. The thing that made it so the task force did not support that was multifold. One is it would have harmed the employers with the lowest operating margins in ways that would have been very concerning. And we're trying to figure out ways to work around that. But the other is the brackets that were placed on the individual income tax would have really created some aggravated problems. Currently, because let's call them the wealthy, but another word might be the top 20%, pay for the majority of all healthcare in the United States. And they do this through their federal income tax, which and state income tax, which pays all of Medicaid. And also, a lot of people don't realize that Medicare taxes, Medicare payroll taxes and the premiums only pay for about half of Medicare. So about half of all Medicare money comes from the federal income tax, which is predominantly placed on the top earners. So moving, I mean, you know, the argument in Senate Bill 770 was we should replace premiums with a progressive tax. Well, that sounds real easy till you realize how much of the care is already being paid by people with high incomes. And there's a question of how much more you can go in that direction. When we opened that plan up to public testimony, there were several doctors who could do the math very easily. And that the plan called for close to 60% of all Oregonians pay nothing for healthcare. So that means a lot of families that now might be paying $17,000, $20,000 a year would suddenly pay nothing. On the flip side of that, the few who do pay the tax would have to pay a very high tax rate. So if you take, now here is the net problem. Access to healthcare in Oregon is limited by the number of providers we have. I know about this because I'm waiting 7 months for an appointment with a PCP. And if we take 40% of the after-tax incremental income of people in the brackets of most healthcare providers, we're really going to harm the supply of healthcare. So, I mean, there was a lot of discussion about this in the task force, and you know, I was urging for more moderation. You know, instead of taking the people in the higher brackets and suddenly they have to pay 100 times what they pay now. Can we do something more moderate where people in the, what I proposed was people in the second and third income percentiles would get like a 20% break on the cost of healthcare in exchange for people in the fifth percentile paying about 20% more rather than paying hundreds of times more. So taxes are never easy, but the tax that we proposed, and particularly the brackets, just seemed out of line to where there wasn't enough people willing to support it on the task force. And that's, but unfortunately, enough time had been spent on that plan that we didn't have a chance to have a second go around. And I might add here, just off the same question, one of the things that we did in 2018 with Mid-Valley that I think was smart is, or turned out being smart, is I designed the tax calculator, and everybody on that subgroup had a chance to go home and design a few kinds of taxes. So we had 16 or 20 different kinds of taxes to choose from. And that discussion really led to a lot of mutual understanding, I think, about what kind of taxes affects people differently, and the ultimate economics of it. And that wasn't the way this task force worked. There was only one proposal, and as Glandora pointed out, it was never really given much discussion. And we could have benefited by looking at a lot more solutions to come up with one that would be more common to people. I really like the book by T.R. Reid, Fine Mess on Taxation. And I like what he proposes, which the best tax is broad-based low rate. So everybody pays a piece of it. And one of the problems, if you've got 60 people, 60% of the people paying nothing, it's hard to have people feel like it's our system, our program. It feels like it's someone else's program. But thanks for allowing me to get 5 answers into one question.
Well, can I follow up with that? Can I follow up with that? If you have spent so much time and so much thought into this issue and still have an impasse, how do you expect the governing board to get over this obstacle?
I have given some thought to that, and I know what I would recommend to them. And I would provide them a more systematic approach, which instead of starting with let's just come up with a tax, start with the principles. Who do you want to pay more? How much more? Who do you want to pay less? How much less? How do you identify those populations? And once you have identified what you want to achieve, then you let that drive the brackets, drive the taxes that you select. I think when you suddenly go to what's the tax, people tend to go more to the extremes. But that's what I would encourage the governing board to look specifically at principles and looking at who pays now and who do you want to pay more and who do you want to pay less and by how much. And then once you've established those, including kind of maximum rates of change, everything else should get easier. But I think there really needs to be, and this is something that I spoke about at several different task force meetings, until we feel like much of the discussion was how to shunt the cost onto someone else, and I said I'm totally opposed to that. I went to my first healthcare forum at the Methodist Church with a checkbook. I was foolish enough to think that we would all just write checks and hold them in the air and that there would be no medical bankruptcy in Benton County for the next year. Since then, I've found that that's not always the case, but I truly believe in citizen responsibility, community responsibility, and I think that's one of the reasons I'm a supporter of state-based or even locally based healthcare, because you feel the responsibility. It's more easy to look at it as something distant when it comes from the federal government or other programs.
Thank you. That's very thoughtful of you. Thank you.
Other questions?
It's Susan.
Hi, George.
Hi, Susan.
With people with disabilities in long-term care, sorry, am talking, in the memory care field, that my husband was in one, and then he passed away. It will be a year ago, this coming January of next year. How do you support with people with disabilities end up in memory care?
The way that the task force answered that question is that the existing programs for low income and low income disability people, those programs would stay in effect as they are now. And those are funded in Oregon through the Department of Health or DHS rather than through OHA. But those programs would not be changed. They'd still be available with both with their good side and with their bad. Because I know there is a lot of complaints about those programs and the clawback provisions and things that sometimes people are pretty unhappy about. But the task force, and this was before I was a voting member, just felt like the long-term care problem is just kind of so big that it would have consumed all our time, and we would have not made much progress on our primary task. Ideas are welcome.
Karen Nibbler.
Yeah, my question is about the different levels of care. Kitts Harbor originally set it up so that there was a cutoff. There were some services that were provided by the Oregon Health Plan, and then there was a cutoff above which they would not pay for. And I'm wondering if they considered any of that in your discussion.
Yes. And the idea is you're kind of combining, let's just generalize, say 3 revenue streams of commercial insurance and Medicare and Medicaid. If Medicare pays $1 for a service, then on average, commercial insurance pays about $1.80 and Medicaid pays about 60 cents. And the idea would be that we would pay a standard rate of, I think it worked out to about $1.27 to providers. And of course, that requires some adjustment, as Bruce Thompson could tell you. It's the reimbursement rates on average. That's what they are on average, but some are very higher or lower. So the idea then of combining those, you also have to agree one standard set of benefits, which the task force chose PEB, public employees benefit level. But at the same time, it may be that there are benefits provided to Medicaid people which would still not be covered by PEB. But the task force is committed to the idea that no one would lose benefits because of the combining of benefits. And it would, because PEB benefits include things like hearing, then when that was extended to people on Medicare, the Medicare population, of course, would get automatically benefits that now they have to pay extra for. So does that answer Does that answer your question? Your point is
Yes, yes,
to try to
you more than
avoid
answered
any-
it. Thank you.
Okay.
Stan Taylor.
Well, I was just wondering if how much money we'd be saving by having just a more efficient Medicare system. I went to the doctor a long time ago, and there was 2 doctors, 3 doctors, and 4 or 5 insurance employees that worked for the doctor that handled insurance. And I was just wondering if inefficiencies in that, how much does that cost us, and how much that would save us?
In looking at the savings that Optum calculated, most of the savings, I mean, when we talk about 12 to 16% total savings, 8 to 12% of that was coming from assumed efficiency by provider in the provider office. That's where most of the savings can come from. The actual savings, like of changing from private insurance, which currently runs around 9% of total healthcare costs, reducing that to 6% would not be as big by removing profits and advertising costs and things like that. So there is some efficiency to be gained everywhere, but the biggest share of it would come from actually provider billing departments, because if billing becomes very simpler or no billing at all on a per patient basis, that's where Optimus advises that the greatest savings would come from.
So this is Mike.
Yep.
This is Mike Warren. I think the Rand report pretty much neglected that part of the savings. Is that your recollection?
No, I think, I mean, the Rand report was looking like about 10% overall savings, but you have to look at where that came from. And part of the difference between Rand and Optimus, their models was Rand estimated that the increased utilization from people having more access to healthcare would cost about 9%. And Optimus said, no, more like 3 or 4%. And so Optimus's rationale and why it's lower is that the system is already supply constrained. So you can't pay more money if there's no more doctors to pick up the charges. So that was really one of the big differences between Rand and Optimus. But in the net, we ended up close to being the same as Rand. Rand had talked about 10% savings and 9% higher cost. So there was about a percentage difference. Optimus, we came up with 12 to 16% savings, but by the time we got done saying, gee, we need more money in behavioral health, we need more money in rural health, and we need other certain adjustments made, we were looking at actually returning only 2 to 4% savings to the public. So the reports are really not as different as you might think that they are.
And where would those savings go? Is there a trust fund?
Well, in the model, it just they were identified as things like, even though the cost to providers would go down by 8 to 12%, we would only count on lowering the payments by 4%. So the idea is that providers would have more money to attract more physicians to fill vacancies in behavioral health and other things that are really gone wanting. A lot of that is adjustable when you get to the plan. You know, if you really decide that the best use of the savings is lower taxes, you can go that way. If you want to turn up the knob on services, you can go that way too. It's not just really one single answer.
Thank you.
At some point, we should try to get questions from folks on the screen. But
Louise Farrell.
Did you talk at all about how to figure out which doctor gets paid how much? There's a big difference between what I call a GP and what some of the high paid ones get. So did you discuss at all how that would be solved?
Yes, and there were numbers of people on the task force who said, "Oh, this will be great. Cardiologists are making too much money, so we'll take money from them and give it to primary care providers."
Yeah.
And my answer to all of that is, you can say what you want. We compete with other states for our physicians and our specialists, and we'll pay what the market pays. We don't really have a choice. We can't have our own rules here where maybe we can attract all the primary care providers in the world, but we can't hire a single specialist. So it's a nice idea, but I don't think you can back it up in terms of actual being able to recruit providers to the state. Thanks for the question.
Oh,
I just wanted to, can we somehow, right now, folks, we can't see the people who are at home very well. So if you want to speak up, or I don't know if anybody on Zoom wants to ask more questions or make comments, but if you've got your hand raised, I can't see you, so that's why we're not calling on you.
I can get everybody else back on here,
Okay.
so you can see them.
And at some point, we'll need to move on, yeah.
We're going to unpin you, Warren.
Okay.
Well, don't go away.
Thanks.
Thank you so much, Warren.
Oh, we got to thank you so much, Warren, coming through.
Absolutely. Thank you for all your insight, all your hours spent with the task force.
Yeah.
Thank you, Warren, so much, from Carolyn.
Did you hear all that, Warren?
Yes, and again, thanks to Mid-Valley, that's really provided a good nest for growing new knowledge and education.
So those of you online, if you do want to ask a question, there's the little reaction icon at the bottom, almost to the right of center. And you click on that and there's a raise your hand icon, or you can just speak up, right?
Well, not seeing any. Maybe we thank Warren and move. Not seeing any hands go up, so maybe we thank Warren and move on to our next speaker. Thank you. Let's all give him a hand.
Yes, thanks very much.